everyone. This is Mike Reiman from Rehab Learning Center. We're going to cover biomechanics. The first portion we're going to look at is the shoulder. Specifically going to look at lever arms. In this position, I'm in prone. As I'm doing shoulder extension, from this position here, this is 90 degrees of shoulder flexion. Once I go from here to all the way up to the end range, where the lever arm is the longest is right there, is when I'm at 0 degrees of shoulder extension. So that's where I have the greatest effect of gravity and external moment arm on my arm. When I'm at 0 degrees, I really don't have any moment arm. The further I go into extension, so there my moment arm is from here to here. Then once I get clear up to here, now my moment arm is a little bit longer because my arm obviously is not any longer, but it is going against the effect of gravity. Now it gets a little bit harder to go into further extension, but that's due to something else because my moment arm is slightly shorter, still very challenging. But the biggest thing now that I'm having problems with, or the bigger rate limiting factor here, is more likely to be active insufficiency. And then this lowering down is I'm going through eccentric control of my shoulder extensors. Gravity is facilitating the motion, not just letting my arm fall down, is taking eccentric control of my shoulder extensors. Same thing when I go into shoulder flexion. My moment arm is from here. So I draw this line vertically and come across. This is my moment arm, my external moment arm. The further I go, so now where my moment arm at whatever I was at 60 degrees was here, now my moment arm is even longer. The length of my arm obviously is the same. The moment arm is changing due to the fact that I'm going higher into and against gravity. The issue also challenging here is similar to extension is my shoulder flexors are becoming more actively insufficient. So that's why the other thing that could limit range of motion here could be overall shoulder motion. I've had bilateral frozen shoulders. I don't have full shoulder flexion. So if you see somebody do this and they don't get to full range, so if I go to range, there's my end range. What you would want to look at is effect of gravity. Is gravity the bigger determinant in strength? Active insufficiency, which you could do in this position, but of course you would want to know that they have full range of motion. If they have full range of motion, you know that ahead of time. I could take their arm and passively bring them up to end range. If that's their end range, then I know I probably have a non-contractile problem as well as potentially a contractile problem. If I can passively raise their arm up to here, then I know I predominantly have an active muscular contraction issue. One thing you can do, instead of doing it passively, is have the patient lie prone like they are, have them go to end range, have them put their arm on the table, and see if they can lift off from here. So you can see I can get a little more range of motion, but where is it coming from? Watch my trunk and the potential compensations that I may be having. Not really rotating the trunk, but it's more coming from scapulothoracic. These are things you'd all want to be watching. So in prone, the greatest resistance for extension is going to be 0 degrees of extension. If I looked at moment arm only. If I had moment arm and active insufficiency, it's going to be end range, shoulder extension, whatever that is. For shoulder flexion and prone, the greatest resistance due to moment arm is going to be the same thing as 180 degrees. If they can go beyond 180, that will be also hard too. It'll be a combination of moment arm and active insufficiency. Let's take a look at shoulder rotation. Couple of ways you could do this. You could do like I am, not supporting my arm. I could scoot over to the right and support my arm. Shoulder stabilization, shoulder scapular girdle stabilization out of play. If you see limited range of motion, You see compensation. Is it coming from glenohumeral joint or is it coming from the scapulothoracic joint? That's one way to potentially control that. Looking at shoulder internal rotation. The further I go up into, the more shoulder internal rotation I get, the greater my resistance external moment arm is going to be, because it's drawn from here to wherever the hand goes vertical. If my hand stopped here, my vertical arm, moment arm would be here. Now my arm stops here. Let's say, it's, 30 degrees. At 10 degrees, my moment arm is going to be shorter. At 30 degrees, my moment arm is going to be longer. My external moment arm that I have to try to use my muscular force to go against. The further I go up, the more the moment arm is going to be. Now this is limiting my into range of motion. So my range of motion is becoming more limited. So again, you would want to look at, well, is it an active problem or a passive problem? And that's why you'd want to look at passive range of motion in such a position to figure out what's the rate limiting factor. External rotation, I'll just let you look at it here first. External rotation's a mess. Here's internal rotation. I really don't compensate a lot at the glenohumeral joint. I don't really rotate my trunk or some things that you see with external rotation. That's all I have. And you can see what I'm trying to do is I'm trying to recruit something else to get that motion. Trying to use wrist extension, trying to drop my elbow down. Now, a couple of things could be limiting here. Why might I be dropping my elbow down? If I look at a couple different variables, here the moment arm is going to be the longest again, the more horizontal I get. If I have 90 degrees of external rotation and my humerus is actually parallel, so it's up here, and I come up here, so this is where my moment arm is going to be the longest. If I actually go to like 150 of external rotation, my moment arm is going to be shorter, but my muscle, I may have more active insufficiency. Again, as always, I would want to look at active versus passive in this type of a position. Some reason that people may want to drop their elbow down, their anterior shoulder may be tight. If I drop my elbow down, I'm stretching less on the anterior shoulder than I would be. My elbow was up here, was up higher. That's going to give more of an anterior stretch to the soft tissue and to the non-contractile tissue in the shoulder. Now, how do you figure out, well, is that a capsular problem, soft tissue problem? A couple of things. You could do contract, relax, see if it gains range of motion. You could do mobilization, see if it changes. Mobilizations and capsular issues aren't going to change as quickly as soft tissue. And often it's a combination of both of those, soft tissue and or capsular. The fact that I had a frozen shoulder bilaterally and before probably has some capsular issues. Now, horizontal abduction. Completely horizontal is where my moment arm is going to be the longest. From here, my axis is here. I draw a line across, and then down to here. Here is my moment arm for this position. If I come up higher, my moment arm is going to get longer because I'm going to have more length in my arm. So you can see now my moment arm here is clear out here versus when I was down in that lower position, it was here. Shorter moment arm in a lower position. The further I come up, again, the same thing as with extension and flexion and shoulder external and internal rotation. Prone is going to challenge all these motions primarily due to the length of the external resistance moment arm. You also want to consider the things that we've already talked about too, is active insufficiency, as well as an active versus a passive restriction. But of course, it's dependent on where your arm is. My arm down on my side doing external and internal rotation, I'm in what's considered a gravity minimized position. So as you see, as I do external and internal rotation here, in prone with my arm like this, I'm not going against gravity. Now if I do sideline and I do shoulder flexion, now is where I'm gravity minimized for shoulder flexion. Of course, gravity is coming down, so the gravity that I'm trying to go against is maintaining my arm in this horizontal position. It's not with shoulder flexion and extension. But now when I go into abduction, my moment arm, where is it longest? My moment arm for shoulder abduction is greatest when I'm at 0 degrees of abduction. This is why if you're in sideline and you have patients initiate shoulder abduction, that's where it's going to be the hardest. Once they get up to 90 degrees, they are gravity minimized. As they go further down so once they go from 90 to 180, gravity is assisting that motion, and they have to work on eccentrically controlling with their shoulder adductors. Looking at external and internal rotation. My moment arm for shoulder external rotation, here's my axis, here's my endpoint, draw a vertical line, here's my moment arm for shoulder external rotation at this position. So it was about this long, so just above my wrist. Now it's lengthened. In sideline, neutral or 0 degrees of shoulder external rotation is where you have the most resistance. So people starting with their arm on their stomach, they're going to, if they're weak, they're going to have a hard time getting to 0 degrees or to neutral. Now going above that, the moment arm exponentially gets shorter because their hand will be moving like this. Active insufficiency comes into play. The muscle is getting shorter and shorter. So this position here, my moment arm is the same as it was. So let's say I'm at 40 degrees of shoulder external rotation. My moment arm is the same as when I was in internal rotation and coming up. So remember when my arm is here, position 1, it's relatively the same position. But this is harder here due to not the moment arm, because the moment arm is the same. The reason this is harder here is now I have active insufficiency to come into play. Now internal and external rotation, just another position. You can see it's relatively gravity minimized. The fact that I'm not completely prone, a little bit of gravity resistance when I'm in this position for external rotation, and then gravity assisting for internal rotation. But it's not a huge external moment arm either way. So remember, shoulder abduction was hardest at 0 degrees of abduction. I'm at a balancing point here where I'm gravity minimized, and then once I go higher into, so from 90 to 180 of abduction as I have gravity assisting shoulder abduction, and I have to eccentrically control with my shoulder adductors. In a position like this, they have to eccentrically, if they go from 90 degrees of shoulder abduction to 80, they have to eccentrically control and use their shoulder abductors to decelerate and drop down at 10 degrees. An eccentric contraction is more efficient. And oftentimes this is a way where you could use shoulder abduction early in range of motion or after injury to allow that control. I could also start from 90 and go to 100, decreasing the moment arm and working short range of motion where the muscle is getting more insufficient, but gravity is also assisting. This is how you can use all these different ranges of motion. If somebody was really, really weak with shoulder abduction, I probably would not want them to start at 0 degrees of abduction. That's where I have the longest moment arm. Probably want to bring them up here and or somewhere where the moment arm is shorter, and then try to work on strengthening in such a position. So again, starting at 90 degrees, you go higher in the range of motion. Gravity is going to assist that motion, probably getting a little bit of contraction from shoulder abductors, but really more of eccentric control from your shoulder adductors. When I move to sitting, where is my external moment arm going to be the highest for shoulder flexion? My external moment arm is going to be the longest and the hardest, I guess, at 90 degrees of shoulder flexion. Well, abduction will be the same way. My hand is furthest from my shoulder at 90 degrees. It is very short at 0 degrees. And it's kind of hard to see from a front view. This is where you always want to consider, okay, what's my external moment arm? What position am I in? How does it change from prone versus supine versus sitting, sideline, all those different aspects. But you can see how I get more shoulder flexion in sitting. My moment arm is a little bit, remember when I was prone, how much trouble I had. Very long moment arm, much shorter moment arm here, but also active insufficiency is relatively about the same in sitting versus prone. But the big variable that's different is the external moment arm was much higher in prone than it was in sitting. So if somebody has very limited end range shoulder flexion, they should show more motion in sitting as I am versus in prone. Of course, one thing you can always do is shorten the moment arm. Simply have them bend their elbow. So in this position, my moment arm is still the longest, but it's not near as long as if my elbow was straight. Always consider all the different variables and the things that you can play with. Shoulder abduction will be the same. If I go back to the starting position, my axis is here. Moment arm, straight vertical, is going to be this long. So about right here. Now if I go to 90 degrees up, so my moment arm before was about here. My moment arm now is clear out here. And it's just due to the effect of gravity. Once I get up to about here, my moment arm will be the same. So my moment arm at 30 degrees of abduction is going to be the same at 120 degrees. The reason 120 may be harder is because now I'm getting into active insufficiency again. And then lowering the arm down in eccentric control. And so this is a mechanism for the drop arm test. Is you bring their arm up, you let their arm go, and then once they get to about right here is when they drop their arm. The reason they drop their arm is their cuff that is supposedly torn can't hold the humeral head in place, so the arm drops. And oftentimes what you'll see people do, they'll volitionally bend their elbow and lean towards their side. They're volitionally trying to shorten their moment arm without even knowing it. And again, you can shorten the moment arm and make it easier. So the reason you may want to do this, let's say somebody's going to shoulder abduction and they're kind of getting, kind of a sticking point where 80 to 120 is they can't really get through that range of motion, but they can go above that and they can go below that. Of course, you can work the ranges of motion below, bring their arm up and go above. What they might do is then just have them bend their elbow and have them work through the range. Or go straight, keep their arm straight, have them raise to where they can. Once they kind of get stuck, have them bend the elbow, work through that range of motion. Once they feel like that's easy, have them straighten the elbow again. External and internal rotation and sitting is in a gravity minimized position. My limitation at in-range external rotation is not going to be due to an external moment. It's going to be due to active insufficiency. Active insufficiency and or shoulder mobility, right? If I have limited anterior mobility, capsule, soft tissue, whatever it is, that may be my limiting factor. Again, now I would have them go to in range. Let's say I stop there. As a clinician, you would possibly see if they could get more. If I get 20 degrees more and I can't hold that position, then I know it's less likely a non-contractile problem. It's more likely a contractile problem. And then external rotation at 0 degrees versus 45 versus 90, which we'll show here. Robert Donatelli did this interesting study, and what he showed at 0 degrees, the limitation primarily here is mostly the subscapularis. The reason this is important is then I could then do contract relax. At about 45 degrees, the limitation is a combination of subscapularis and anterior capsule. Remember, on your anterior capsule you have superior, middle, and inferior glenohumeral ligaments. If I look at shoulder external rotation here, if I look at the capsule only, the inferior glenohumeral ligament is going to be very slack. Middle is going to be slack. Superior is probably going to be the most taut, but Donatelli's work would suggest it's mostly limited by subscapularis. So if I'm limited there, I'm probably going to do contract relax. Versus if I'm limited here, I'm going to try to figure out, well, what am I at 90 degrees? And if I'm limited at 90 degrees, so you can see I struggle here more, but also, well, let's just take one thing at a time here. The belief here is this is primarily anterior capsule. If I notice I'm more limited at 90 degrees versus 0 degrees, the Donatelli study would suggest, well, that's capsular restriction anteriorly. The additional issue here, though, is external moment arm. Because here I'm gravity minimized. I don't have an external moment arm for external rotation. Once I get up to here, I have a large moment arm, right? But if I get past that and I'm kind of stuck here, I don't have my moment arm anymore, but I also have more active insufficiency. You want to play with, okay, is it passive? This is why you would have them do all three positions actively, but then check the passive range of motion after each one and see what it is. So now side view, shoulder flexion, very short moment arm here, external moment arm. Here's my axis. If I draw a vertical line here, here's my external moment arm. Versus at 90 degrees, that's where my moment arm is going to be the longest. And that's why shoulder flexion and the sagittal plane in sitting is hardest at 90 degrees. Versus it's hardest in prone at 180 degrees. I mean, if I look at moment arm only. And then also active insufficiency in prone is more challenging. Versus active insufficiency here is also more challenging at 180 degrees. And you can see I still have some limitation there. But once I bring my elbow and shorten my moment arm, I seem to get to relatively the same position, but of course you would want to look at if this was a patient, you would want to compare active versus passive. Because if I bend the elbow and I go much further than they did with the elbow straight, then I know it's probably more of an active contractile problem versus passive. And then again, just showing external rotation, really not any external moment arm. But again here, once I'm at 90, well, I'm not quite at 90 degrees, but at 90 degrees. So at 90 degrees, my external moment arm is longest here. Here's my axis. Here's the length of my moment arm. The further I go up towards 90 degrees, my external moment arm will shorten because my hand won't be moving like this. But it can get harder because of active insufficiency, active muscle strength. So my moment arm is essentially nil here. So if I'm having problems getting to here, is it active insufficiency and or is it tightness on the anterior portion of the shoulder? It's not a external moment arm problem. And then going internal rotation would be gravity assist. Cervical spine, some of the same kinds of things here. Now, here's a way you can strengthen on your side flexors. My moment arm is going to be longest when my head is in neutral. But again, then I get into active insufficiency of my side flexors. In a prone or supine position, my side flexion will be relatively gravity minimized. The issues there are going to be limitations in motion. It's probably going to be harder to get to end range because of active insufficiency. The other issue is potentially the friction from the table. In prone, it's ideally a position to work on cervical extension. Here's my axis. The length, I guess, of my head is going to be longest in neutral. The further I go into extension, my external moment arm will shorten. And I also get more active insufficiency. If I look at where cervical extension is going to be the hardest due to an external moment arm, it's going to be in a neutral position from where I'm starting versus end range. One thing to consider here too is cervical extension versus cervical and capital extension. This is normal cervical extension. This would be what's called capital extension. your deep subcapital extensors. Generally, the instruction when you're doing manual muscle testing is if I want to look at capital extension, I instruct a patient in prone position to look at the table or the wall in front of them. What I'm trying to do here, and not doing a very good job, is if you trail them to look up at the ceiling, if they're in a room, that's combining capital and cervical extension. The first video that we showed here, where I'm simply going straight up, that's cervical extension. Looking at the wall in front is capital extension. Looking at the ceiling above, which this is supposed to be, is combined cervical and capital extension. Something you could do here is get them off the table. So a progression would be, we'll start them deeper in flexion, or start them without a stable base. So now I can start deeper in flexion, where the moment arm is slightly shorter, and then just have them come up to neutral. Or I can play with capital and cervical extension. Most people are going to be fine with capital extension because their deep suboccipital muscles are very strong. But now this gives you more range of motion. You can start deeper in flexion than I am. Now if I look at side flexion, again, I can start even further down. So remember, if we were on the table and we started in neutral, that's where we're going. That's where the external moment arm is the strongest or the hardest. If I start them in right side bending, moment arm's a little bit shorter, and as I come up, it'll get slightly longer. So you can see the tip of my head is further away than when I was down here. So here's the tip of my head in this position. And then it's just a little bit further. So it's not a big difference. But the further I go, it gets a little bit harder. So you can see I'm having more problems. But that's probably due more to active insufficiency and or limitations in motion versus an external moment arm. Because my external moment arm was longest when I was in neutral. Cervical flexion, so deep neck flexors. Again, you can look at the longest coli, longest capitis for trying to bring the chin towards the Adam's apple is typically the instruction. I can look at capital flexion, cervical flexion, and or combined. Capital flexion, the instruction typically is try to bring their chin towards their Adam's apple, keeping their mouth closed. Cervical extension is have them lift their head up without, keeping their eyes straight, keep looking at the ceiling. And then combined is have them lift up and look down towards their feet. Now you're combining OA flexion, so chin towards Adam's apple, plus cervical flexion. That would be cervical. You're not getting any OA flexion. Your head is staying in neutral. You're not looking towards the feet. You're not bringing a chin towards Adam's apple. This would be not your deep neck flexors, like your longest coli and capitis. So if somebody comes up and does that, and you tell them to look, that you wanted them to look at their feet in the first place, and they do that, then you're suspicious of longest coli and capitis weakness. Because what you should see is that, where they go up and then they look at the feet. One thing you can always do is start from a supported position. So have them start in some degree of flexion, shorter external moment arm, more actively insufficient, and then just have them work on the short ranges of motion. So if they're having trouble getting in range, but they have the motion, so they have the passive motion, they just lack the strength, what you could do is bring them up in that position, have them support that, and or you support that, have them lift their head up off your hand, and watch. Are they looking towards their feet, and are they straight, are they going straight up? Are they working the longest coli and capitis? You can obviously work on eccentrics as well. And if somebody's weak, as a clinician, I'd have my hands underneath here, but you could start in a position like you had them and then just let them lower their head down slowly. Remember, eccentrics are more efficient. Just make sure that they have the motion. Then you can have them work through a larger range of motion. If I'm working on more and more strength, I can work on a larger range of motion. Now let's look at the hip. So sideline, we're going to look at hip abduction. If I look at abduction, how is it different in standing versus sideline? Well, sideline hip abduction is going to be hardest in a neutral position because my moment arm, here's my axis, my moment arm is clear out here. Versus if I stand, where my moment arm is going to be longest is the further I get into abduction. So standing abduction at 0 degrees is the easiest. Sideline hip abduction at 0 degrees is the hardest. The further I go higher into abduction in sideline, the shorter my external moment arm. The further I go into standing hip abduction, the longer my moment arm. So if I look at moment arm only, 0 degrees of hip abduction is very easy in standing. It's very hard in sideline. So now my moment arm is only this long versus my other one was clear out over here. But again, now you get into active insufficiency and overall joint mobility. And you obviously want to make sure that they're staying in the frontal plane, they're not dominating with TFL. Sideline hip flexion, relatively gravity minimized. Same with hip extension. Now you can look at, do I have the motion? Versus if I go in prone, now hip extension is going to be harder. Now let's look at this though. If I'm in prone, here's where my moment arm is longest, 0 degrees. Okay, if I was supine and did supine straight leg raise or hip flexion, it's going to be longest in 0 degrees as well. This is why some people can't do straight leg raise in supine position, because that's where the hip flexor has to work the hardest. Versus in standing, it's going to be easier for hip flexion. Now, one thing I want you to consider is why is it hard for me to get to end range? So 20 to 30 degrees, so it's about normal. But here again, here's where you're getting into active insufficiency again. Now, a question I want to ask is, where do we always do manual muscle testing? Ideally, a muscle is strongest at its mid-range, where it gets maximum overlap of myosin and actin. Shoulder flexions at 90 degrees. We talked about that's where the moment arm's the longest. This is where we do hip extension manual muscle testing. Moment arm's a little bit shorter than at neutral or at 0 degrees, but now I'm running into active insufficiency. So is this really the best position to test hip extension? Or is this a good reason why almost everybody's hip extension is weak? It probably should be weakest there. And of course, if I shorten the moment arm, now I try, the manual muscle testing books will tell you try to isolate the glutes a little bit better. If I drop off the side, now I'm shortening the moment arm, putting in where the glute max works ideally is at about 70 degrees of hip extension. Maybe this is a type of a position that we should test them in, especially if we're doing handheld dynamometry, which we should be. Manual muscle testing is not sufficient. So now going through the range of, so this is a way where I could work through a larger range of motion. Can bend as they come up. So because what's going to happen, remember, is I'm going to be fine here as I go into hip extension. Then where I'm going to get trouble is here. So what you're going to see people naturally do is they're naturally going to bend their knee. They're not thinking, hey, Mike, you know what? If you bend your knee, your moment arm is shorter. You have less external moment arm. They're just trying to get up. So these are natural compensations you will see. And these are biomechanical reasons why they're doing those. I typically don't look at internal and external rotation in this position, but this is interesting. In this position, I'm relatively gravity minimized. Now, in this, depending on where my leg is, but you can see I'm still having some trouble. And part of it is due to gravity, but other issues are as well. Now, if I look at internal rotation and external rotation in a sitting position. In a neutral internal external rotation, I have no external moment arm due to gravity. Now my internal moment arm in this position here, say 20 degrees, here's my axis, here's my end point, here's my external moment arm. The further I go out, the longer my moment arm is going to be, and the harder it's going to be to go up against gravity. So that's a little bit longer, and you can see I'm having some issues there. Now again, coming into play is potentially active insufficiency and joint mobility. So you'd always want to check those as well. Same thing for external rotation. You can see how I compensate a little bit. The further I go up, the longer my moment arm is, the more actively insufficient I am, and the potential more for joint mobility restrictions. When I'm doing a range of motion in a position and it's limited, check active versus passive, check joint mobility, but then also consider active insufficiency, passive insufficiency, and external moment arms. Now, one thing I want you to ponder here is, look what I did here. I'm not just being lazy. Now I lean forward onto my hands. How does that change range of motion? A little bit more limited with internal rotation and harder. External's about the same. What do you think's going on here? All right, everybody, ponder that. Take care.